Welcome back to Roadmap to Residency. Today we work through ear, nose, and throat infections as they appear on Step 3, middle ear infection, outer ear canal infection, sinus infection, sore throat, and the pediatric airway emergency. This is a question strategy session, not a lecture. We will look at how the stems are written and which distractors are planted to catch you. Keep your question bank open and a trusted review resource nearby. If this helps, please like and subscribe. Let us begin. Here is the plan. First, middle ear versus outer ear canal infection, where the exam finding hands you the answer. Second, sinus infection, where the writers test whether you can count days. Third, sore throat and the 4-point score, where the number of criteria drives the next step. And fourth, the child who drools and refuses to lie down, an airway emergency where the tempting answer is wrong. Read the explanation for every question, including the ones you got right. What we add is the strategy layer that turns knowledge into points. First strategy, separate the middle ear from the ear canal before you read a single answer choice. Go straight to the exam sentence. A bulging, immobile, or red eardrum with middle ear fluid in a child with fever and ear pain means the middle ear. Pain when the outer ear is pulled, a swollen draining canal, and a normal eardrum means the canal. That one sentence eliminates half the choices. Now the trap. The older diabetic with severe pain out of proportion and granulation tissue in the canal. It sounds like swimmer's ear, but it is the invasive skull base infection, and the answer moves toward imaging and intravenous therapy, not drops. A 16-year-old swimmer with 3 days of ear pain and itching, no fever. Pulling the outer ear reproduces the pain. The canal is swollen with debris and the eardrum is normal and mobile. What is the most appropriate next step? Choice A, topical drops with an antibiotic and a steroid. Choice B, oral amoxicillin. Choice C, computed tomography of the temporal bone. Choice D, referral for ear tubes. The exam finding decides this in one sentence. Pain on pulling the outer ear, a swollen canal, and a normal mobile eardrum place the infection in the canal. A healthy teen with an intact eardrum and no systemic signs gets topical therapy. The answer is topical eardrops with an antibiotic and a steroid. Now the distractors. Oral amoxicillin treats the middle ear, which the stem cleared. CT of the temporal bone is the escalation trap, reserved for the diabetic with pain out of proportion and granulation tissue, none of which appear here. Ear tube referral addresses recurrent middle ear fluid, which this patient does not have. Every wrong answer moves to the wrong space or escalates without a trigger. Strategy 2. Sinus infection here is a timeline question, not microbiology. You decide viral versus bacterial, and duration is the discriminator. Improving within about a week means viral, and the answer is supportive care. Persisting beyond 10 days, or opening with high fever and thick purulent drainage for several days, points to bacterial. The highest yield stem is double worsening. The patient improves, then declines again, better by day 5, then new fever and worse facial pain by day 7. That second decline is the bacterial signal, buried mid-sentence, so train yourself to catch it. One more scan. Swelling around the eye, pain with eye movement, or double vision means the infection has left the sinus. That becomes imaging and admission. The timeline is doing all the work in this one. A 34-year-old woman with facial pressure and congestion for 11 days. She improved by day 5, then worsened 4 days ago with fever and thick drainage. No eye swelling, no pain with eye movement, no visual change. What is the most appropriate next step? Choice A, oral amoxicillin with clavulanate. Choice B, reassurance and supportive care with saline irrigation. Choice C, computed tomography of the sinuses. Choice D, admit for intravenous antibiotics. Double worsening is the whole question. She improved, then declined again with new fever and thick drainage, and her duration is past 10 days. Stable, no red flags, so this is bacterial managed as an outpatient. The answer is oral amoxicillin with clavulanate. The distractors. Saline irrigation and supportive care fit the viral course and would be right on day 4 while improving, but the second decline and 11 days rule it out. CT of the sinuses adds cost and radiation without changing management because the diagnosis is clinical and the stem clears the orbit. Admission for intravenous antibiotics belongs to the patient with eye swelling, pain with eye movement, or vision change, all explicitly denied. The 2 failure modes, undertreating by ignoring the timeline, and overtreating by ignoring the absent red flags. Strategy 3. Sore throat runs on a 4-point score. 1 point each for fever by history, tender front of neck lymph nodes, tonsillar exudate, and absence of cough. Age adjusts up for children and down for older adults. The hard part: the stem scatters the criteria across sentences and mixes in irrelevant detail. Tally the points in the margin before reading the choices. A low score means no test and no antibiotic. An intermediate score means test with a rapid antigen test and treat only if positive. A high score supports treatment, though testing is still reasonable. Watch the viral words. Cough, runny nose, hoarseness, and pink eye are planted to drag your score down. The exam is testing whether you test before you treat. Score this one in the margin as you read the stem. A 22-year-old man with 2 days of sore throat. Subjective fever, no cough. Temperature of 38.1 degrees Celsius. Tonsillar exudate, and tender enlarged lymph nodes at the front of the neck. No runny nose, no hoarseness, no difficulty breathing. What is the most appropriate next step? Choice A, reassurance and supportive care with no testing. Choice B, rapid antigen detection testing of a throat swab. Choice C, prescribe azithromycin without testing. Choice D, obtain a lateral neck radiograph. Tally the criteria. Fever, 1. Absence of cough, 1. Tonsillar exudate, 1. Tender front of neck nodes, 1. At 22, age is neutral. That is a high score. Here is where students overreach. A high score does not license skipping the swab in a well-appearing outpatient. Confirming before committing to an antibiotic is the Step 3 instinct. The answer is rapid antigen detection testing of a throat swab. The distractors. Reassurance with no testing fits a patient loaded with cough, runny nose, and hoarseness, all deliberately removed here. Azithromycin without testing fails twice. It treats without confirming and reaches for a broader agent when the narrow one is preferred. A lateral neck film belongs to the child with drooling and noisy breathing, not this comfortable adult. Is strategy 4, and it appears on every exam. The Pediatric Airway Emergency. Recognize the posture. Rapid onset high fever, muffled voice, drooling, and noisy breathing in a child leaning forward on outstretched arms who refuses to lie flat. If immunizations are not up to date, the writers are underlining the diagnosis. The danger is that it reads like a bad sore throat, and the tempting choices are what you would order for one. The correct first move is to keep the child calm and secure the airway in a controlled setting, with the operating room prepared and specialists present. Do not use a tongue depressor, draw blood, or send the child to radiology. Any choice that agitates the child or delays the airway is wrong, and that rule eliminates 3 of 4 choices. This is the emergency, and the clock is running. A 4-year-old boy with 6 hours of high fever, sore throat, and a muffled voice. He is drooling, sitting upright and leaning forward, and refuses to lie down. He has noisy breathing on inspiration. His immunizations are not up to date. He appears anxious. What is the most appropriate next step? Choice A, examine the throat with a tongue depressor. Choice B, obtain a lateral neck radiograph in the radiology suite. Choice C, take the child to the operating room for airway management with anesthesia and otolaryngology present. Choice D, obtain blood cultures and start intravenous antibiotics at the bedside. Airway before everything. Fever, drooling, a muffled voice, forward-leaning posture, noisy breathing, and incomplete immunization describe an airway that can close at any moment. Nothing from a test changes what you do first. Secure the airway in a controlled setting with anesthesia and otolaryngology present. That is the answer. The distractors. The tongue depressor is the most dangerous choice because agitating this child can cause complete obstruction, and a choice that can kill the patient is never the next step. Sending an unstable child to radiology removes him from rescue equipment and changes nothing. Blood cultures and antibiotics at the bedside are seductive because both are genuinely needed, just not first. When 2 actions are both correct, the exam asks which comes first, and the answer is the one that keeps the patient alive. Step back at what we did 4 times. Nearly every wrong answer belongs to one of 3 species. First, overkill. Imaging or admission for a stable patient with no red flags, like the temporal bone scan in the healthy swimmer or the sinus scan with a clear orbit. Second, undertreatment. Reassurance when the stem stripped out every viral feature or the duration crossed the threshold. Third, wrong sequence, a necessary action offered at the wrong moment, like blood cultures in the obstructing child. The routine. Read the last sentence first, find the exam finding and the timeline, ask whether any red flag is present, and note when the stem denies red flags, which tells you not to escalate. Then sort the survivors into overkill, undertreatment, and wrong sequence. What is left is your answer. Let us bring it home. Drill these infections in your question bank until the exam finding, the timeline, and the red flags jump off the page. Pair them with one trusted review resource and read every explanation, including the ones you got right, because that is where the real learning hides. Practice under timed conditions until the elimination routine runs by itself. If you want help building a plan, visit roadmaptoresidency.com, where our tutors and advisors work with students one-on-one. If this video helped, please like and subscribe. Good luck on your exam, and we will see you in the next one.